Upper gastrointestinal bleeding is a common cause of hospital admission. Although the incident rate is declining slightly, there are still 61 to 134 bleeds per 100,000 patients per year, and the mortality remains considerable. The most common cause of upper gastrointestinal bleeding is peptic ulcer bleeding with Helicobacter pylori infections and or the use of non-steroidal anti-inflammatory drugs, including low-dose aspirin, being the most important risk factors. Rebleeding is a frequently observed complication of peptic ulcer bleeds, and the potential occurrence of rebleeding often prevents early discharge from hospital. Patients who are at a high risk of rebleeding or mortality are often closely monitored or admitted to the intensive care unit. Reliable prediction of rebleeding and or mortality is difficult. Several risk scores based on clinical input parameters have been developed over the past decades for predicting the outcomes of peptic ulcer bleeding. However, the use of these scores in clinical practice remains unknown, and gastroenterologists seem to rely more on their own clinical intuition or on simple classifications such as the Forrest classification. The Forrest classification was developed almost 4 decades ago. The purpose of the classification was initially to uniformly describe lesions that are or have been bleeding. However, the Forrest classification, or at least stigmata of bleeding, is nowadays mostly used to identify patients who are at an increased risk for rebleeding and mortality. The Forrest classification differentiates ulcer with a spurting hemorrhage, Forrest 1A, and oozing hemorrhage, Forrest 1B, with a visible vessel, Forrest 2A, and adherent clot, Forrest 2B, hematome on the ulcer base, Forrest 2C, and a clean ulcer base, Forrest 3. Rebleeding rates reported in literature vary between 90% for a Forrest 1A lesion and 5% for a Forrest 3 lesion. These rebleeding rates for different Forrest classes were reported many years ago, and much has changed over the past decades regarding not only the etiology but also the treatment of peptic ulcer bleeding. The use of intravenous proton pump inhibitors and the development of endoscopic treatment has improved the outcome of peptic ulcer bleeding considerably. The aim of the study, therefore, was to reassess the Forrest classification in predicting the outcome of peptic ulcer bleeding. More specifically, the study tested whether the Forrest classification had better test characteristics in gastric ulcers compared with duodenal ulcers, and whether a simplified Forrest classification could be an alternative to the original classification. De Groot et al. Have the following things to say. Background and study aims. This study aimed to reassess whether the Forrest classification is still useful for the prediction of rebleeding and mortality in peptic ulcer bleedings, and based on this, whether the classification could be simplified. Patients and methods. Prospective registry data on peptic ulcer bleedings were collected and categorized according to the Forrest classification. The primary outcomes were 30-day rebleeding and all-cause mortality rates. Receiver operating characteristic curves were used to test whether simplification of the Forrest classification into high-risk Forrest 1A, increased risk Forrest 1B to 2C, and low-risk Forrest 3 classes could be an alternative to the original classification. Results. In total, 397 patients were included, with 18 bleedings being classified as Forrest 1A, 73 as Forrest 1B, 86 as Forrest 2A, 32 as Forrest 2B, 59 as Forrest 2C, and 129 as Forrest 3. Rebleeding occurred in 74 patients. Rebleeding rates were highest in Forrest 1A peptic ulcers, 59%. The odds ratios for rebleeding among Forrest 1B to 2C ulcers were quite similar. In subgroup analysis, predicting rebleeding using the Forrest classification was more reliable for gastric ulcers than for duodenal ulcers. The simplified Forrest classification had similar test characteristics to the original Forrest classification. Conclusion. The Forrest classification still has a predictive value for rebleeding of peptic ulcers, especially for gastric ulcers. However, it does not predict mortality. Based on these results, a simplified Forrest classification is proposed. However, further studies are needed to validate these findings.